Thank you, Professor Bassi. Thank the organizers for giving me the opportunity to elucidate this topic towards a fistula-free distal pancreatectomy. But I'm not sure when I end up this talk in 20 minutes, we are totally free of this complication. The first series and the largest series is from the Johns Hopkins, published by Lidemo some years ago already. And a large series of 235 patients with benign and malignant indications for distal pancreatectomy. 84% had splenectomies, half a liter of blood loss. Mortality was low with only 1%, but complication rate was fairly high with 30%. But according to the definitions in those days, there was a pancreatic fistula rate of 5%. Diabetes 8%, and hospital stay was 10 days. So they concluded that it was a safe procedure, but still we have a fairly amount of complications. The indications for distal pancreatectomy are a variety. Of course, the malignancies, pancreatic cancer and the lower malignancy rate of the neuroendocrine tumor, but also the lesions with pre-malignant lesions or even the benign lesions. So there is a different indication and also different textures of the pancreas. What kind of resections can we do for those lesions in relation to distal pancreatectomy? Of course, we can do pancreatic sparing procedures like enucleation and central pancreatectomy, which I'm going to compare for you. But also the somewhat larger procedures like the RAMS or the distal pancreatectomy in combination with a celiac artery resection described by Appleby. We're going to talk about splenic preservation with or without a splenic vessel resection and the indications for laparoscopic resections. First, enucleations. This is a study of 473 patients for pancreatic surgery, of which 133 had a neuroendocrine tumor. And what they did, they analyzed the risk factors on pancreatic fistula. And what they found in this study, that the fistula rate, as compared to the others, was higher in the group of enucleations. Of course, that was mostly due to an indication of a neuroendocrine tumor, but still enucleation did not reduce, but even made them higher. Fistula rate increased to almost 40%. Central pancreatectomy was nicely reviewed in the British Journal of Surgery last year of almost 1,000 patients in 94 studies with a low mortality, below 1%, but a pancreatic fistula rate over 40%. Endocrine insufficiency, only 5%. And they performed a meta-analysis of only 12 studies included in this review, and they showed that there indeed was, by this pancreas sparing procedure, a lower risk on endocrine insufficiency. But where they also showed nicely that the rate of postoperative morbidity and pancreatic fistula was higher, significantly higher, in those patients with a central pancreatectomy, which is obviously due to the double anastomosis. The more extensive resections, as described by Strasberg, the RAMS procedure, not to reduce the pancreatic fistula, but to increase the higher rate of R0 resection, which is for pancreatic cancer, of course, most important. And the same yields when there is an involvement of the celiac axis, whether it is justified to add this arterial resection to the distal pancreatectomy. And what he showed, that in his series, the complications and pancreatic fistula rate equals performing a RAMS versus a distal pancreatectomy. But what he also showed, that when doing this somewhat more extensive procedure on the dorsal side of the pancreas, the median survival increased to 26 months and a 5-year survival to 35%. And that equals to the other series in the world who are using the same procedure here in Asia. What about splenic preservation? We have two techniques, one described by Kimura, where all the small vessels from the splenic vessels to the pancreas are meticulously ligated, and the vascularization of the spleen is not hampered, and the spleen can be preserved. The other procedure by Warsaw, by which the vessels are at the site of the transection, the artery and the vein are ligated on both sides, and the spleen could be preserved vascularized by the short gastric vessels. There is in HPB of last year a nice systematic review on comparing those techniques. And it clearly showed that the Warsaw technique was quicker with a shorter operative time, significantly shorter, significantly less blood loss, and even the length of stay was significantly shorter. So obviously the Warsaw technique is easier and quicker to perform than a splenic vessel preservation. But in the same analysis, they also showed that the spleen-related complications are increased when using the Warsaw technique. 2% of the patients in the Warsaw technique still need a post-operative splenectomy, and splenic infarction was seen in 22% of the patients. And maybe more important, the chronic left-sided abdominal pain was encountered in the Warsaw technique in 38% of the patients, which to my opinion probably is a somewhat unknown complication of this technique. So they concluded in this analysis that the splenic vessel preservation is technically more demanding, or probably preferred, especially for the longer-term or spleen-related complications. This is what you can see when you perform such a procedure laparoscopically. Comparing laparoscopic distal pancreatectomy with the open technique, a several amount of meta-analyses are performed in the last years. This is one of them, including almost 2,000 patients. It clearly showed there was less blood loss, hospital stays reduced, and complications as well when comparing laparoscopic procedure with the open technique. But the operation time after a learning curve, of course, is equaled. The R0 rate is equal. The fistula rate is the same, as well as mortality. And of course, the long-term oncological outcomes are so far unknown. And they conclude that performing a laparoscopic distal pancreatectomy is safe and feasible, but in selective cases. But the question is, of course, how to select these. This is another meta-analysis showing that the pancreatic fistula rate comparing 1,500 patients laparoscopically and open are the same for both procedures. But in this analysis, they showed that the significant fistula was, although not significantly, almost not, it was significantly somewhat higher, 15% versus 10%, when looking only to the significant fistula in these meta-analyses. And what I try to do is to find risk factors for this pancreatic fistula. And what I found in a multivariate analysis that 4 factors were still a factor when comparing the rate of pancreatic fistula in the open and the laparoscopic technique. BMI below 27, a diagnosis of being not an adenocarcinoma, a pancreatic specimen length of less than 0.5 centimeters, and splenic preservation. And the first 3 of these could obtained pre-operatively, and when you obtain those patients, the fistula rate in this meta-analysis can go down from 40.1% in the open when performing this procedure to a laparoscopic procedure to only 2%. So maybe these are the patients who are the most suitable for laparoscopic procedures. In reduction of pancreatic fistula after distal pancreatectomy, of course the technique of closure is very important. In 2005, this systematic review and meta-analysis was performed in more than 1,000 patients to compare all the different closure techniques. The meta-analysis only included 6 studies with almost 500 patients, comparing the most studied techniques, meaning the suture line and the stapler line technique. The postoperative pancreatic fistula rate using a stapler was about 23%. And for using the Hansoon suturing was about 35%. Suggesting any difference, but this was not significantly different. And therefore it was concluded from this study that a large randomized trial was needed to see whether the stapler closure can reduce fistula rate after distal pancreatectomy. And from Heidelberg it was initiated and performed in 21 European centers, including 450 patients, published in The Lancet in 2011, but the pancreatic fistula rate did not go down by using the stapler technique. In the stapler technique, it was 32%, and on the hand technique is 28%, which was not significantly different. And when we add this study into all the studies, including the randomized trial of our chairman of this session, it was shown that even in those combined analysis, there was no significantly different in using the stapler or the hand-sewn closure of the pancreatic stump. They concluded, therefore, maybe we should add some new techniques in closure, adding to the stapler or adding to the hand-sewn. A lot of techniques are described, and I'm going to take you through what is the relation to the pancreatic fistula rate. First, the stapler reinforcement, already described several time ago, and on this retrospective analysis of 85% of the patient, the stapler line was reinforced by a bioabsorbable seam guard. 38 patients in the standard group, only the stapler used, 26% pancreatic fistula. But only 4% in the 407 patients, they reinforced the stapler line with a seam guard. But this is only a retrospective study, but it showed significantly advantage of the enforcement. This is also a retrospective study of almost 150 patients. 25 patients had a reinforcement, and they found in this series a pancreatic fistula rate of 14%. But the only risk factors for developing a pancreatic fistula was the persistence of diabetes and the stapler size. And reinforcement surely did not reduce the pancreatic fistula rate in this series. Also on this topic, there was a meta-analysis performed. In 10 studies, half of them had a mesh enforcement. Pancreatic fistula rate in this study was 21%, reinforced 17% pancreatic fistula rate, and 24% when using the standard stapler technique. Not significantly different, so there was no clear evidence for benefit of reinforcement to reduce the pancreatic fistula rate in distal pancreatectomy. Fibrin glue, already described almost 20 years ago to reduce pancreatic fistula. It was a randomized trial, a small trial of 56 patients with pancreatic or gastric cancer, standard hand-sewn suturing technique, and only fibrin glue was added, reducing the fistula rate from 40% to 15%, which in this series was significantly different. But a much larger series is recently performed in 19 centers, more than 100 patients, and they selected only those patients of a soft gland, 101 patients, and they randomized it to fibrin glue in combination with a falciform patch. 50 patients with a falciform patch and 51 with a standard stapler or suturing line. And these are the results. In this 101 patients, the fistula rate was totally the same in both groups. 20% when all fistulas were taken into account, and only the clinical significant fistula was 18 versus 17.6%, which of course is not different significantly. So they showed no advantage of a combination of a falciform patch with fibrin glue on the rate of pancreatic fistulas after distal pancreatectomy. Other ways to reinforce or cover the distal stump. This is a recent study in 19 centers, 275 patients, standard hand-sewn or stapler technique, and a fibrin glue patch from Tagasil was added in a randomized study. Pancreatic fistula rate was fairly high, but most of them were grade A fistulas, and a grade B or C fistula were with a fibrin patch 8%, and although it's slightly higher, without a fibrin patch of 14%, there was no significantly different. So they concluded that there was no advantage of putting a fibrin glue patch on the pancreatic stump after closure, either with stapler or hand-sewn. Other ways to reinforce the stump. A randomized trial of 70 patients with the stapler closure, and they performed reinforcements with a seromuscular patch of a jejunal loop. Not opening the bowel, just suturing the loop to the staple line. Although the overall pancreatic-related complications were significantly lower when they added a seromuscular patch, it does not yield for the rate of grade B or C fistula. The difference was not significantly different. When opening the bowel and making it through anastomosis, there was only retrospective studies of 43 patients published in 2007 showing in this retrospective series that they actually had no fistula in the group of patients with Roux-en-Y pancreatic jejunostomy. No pancreatic fistula were found in this series, so this is the only series which shows that we are towards a fistula-free distal pancreatectomy, but unfortunately this is without any sure evidence at the moment. Do we have other methods to reduce the fistula rate? Pancreatic stent is suggested on retrospective and case studies that it could lower the pancreatic fistula rate because it's also used for treatment of persistent pancreatic fistulas. And it was concluded that randomized control trials are needed to prove the value of this stenting. But a recent randomized trial in 58 patients from Sweden with a distal pancreatectomy closed with a stapler technique, and during operation an ESCP was performed to put a stent in the pancreatic duct, but it showed no significantly different. And when you look at the figures, without a stent 22%, but with a PD stent it might even increase to 42%. But there was no significant difference. But at least they concluded that prophylactic pancreatic stenting does not reduce the rate of pancreatic fistulas after distal pancreatectomy. What about somatostatin? It's extensively studied in pancreatic surgery in multiple trials, and the last Cochrane analysis of last year showed a reduction in complication, a reduction in pancreatic fistula, but no clear difference in clinically relevant fistula. No impact on mortality, but still it was recommended for routine use in this Cochrane analysis in pancreatic surgery. But in relation to this talk and the distal pancreatectomy, there were no subgroup analysis performed for distal pancreatectomy in this Cochrane analysis. Ladies and gentlemen, Chairman, in conclusion, the technique of distal pancreatectomy is a safe procedure, but the postoperative pancreatic fistula is still unsolved and is still a fairly high amount of 10 to 30% of the patients. Pancreatic sparing procedures might reduce the long-term endocrine insufficiency, but leads to more pancreatic fistulas. Spleen preservation should be performed if it's possible and justified for oncological reasons, and preferred to perform with preservation of the splenic vessels. Laparoscopic resections can be performed safely and could perform in selective cases. About the closure of the pancreatic stump, unfortunately we still don't have evidence for any preferred closure technique. Although studied extensively, we don't know which one to use, and most surgeons do it at their preference. Stapler equals Hansoon in a randomized trial shown. Mesh reinforcement, multi-analysis, no better on reduction of pancreatic fistula. Fibrin glue and falciform patch, not better. Even not with a sealant patch, no improvement on the rate of pancreatic fistula. Seromuscular patch, not in a randomized trial. The only difference we found was a pancreatic anastomosis performed, but is only in a small retrospective study. And I truly believe that when we are going to evidence-based pancreatic-free distal pancreatectomy, we maybe should perform a randomized trial to find whether this is the best way to go. Thank you very much for your attention.